Mr. President, ladies and gentlemen, thank you very much for that nice invitation, and thank you very much to the Royal Society of Medicine for inviting me to give this talk, which I was really very honoured to be asked, and most surprised, and much more surprised when I saw the list of all the far more illustrious people who've given it before me. But I wanted to thank you all the audience also in particular, because I know you all have busy lives and have very many things that you might like to be doing rather than cooped up in here listening to me. So I do hope that you do come away with one or two useful little snippets, and that it was worth missing the Chelsea game tonight. So now, let me now first of all go on to a word about the benefactor who gave the money for this lecture. And this was Edwin Stevens. And Edwin Stevens, his daughter-in-law is in the audience in the middle of the front row. And he was an inventor and philanthropist. He was born in Monmouthshire, and he was a very clever student, won the school prize. He went on to University College Cardiff, and then, as every good Welsh intellectual, went on to Jesus College, Oxford. Here it is, founded by, and have a long tradition with Welsh connections. And here he is at perhaps the peak of his powers, and he was the inventor of the world's first wearable hearing aid. So he helped enormous numbers of people, far more people than I will ever help in my life, because he can help people to hear. Also, Amplivox must have been a great success. Anyway, word got to Churchill, who had become deaf, and probably he had been in many battles, but not just in battles. He has check for the gadget. The prices have risen slightly since then. And then here is his audiogram, which shows that he has noise trauma deafness. And so this is, the low tones are okay, so you'd have to speak to him like that. But if you spoke to him like that, he wouldn't hear you. And because both sides, both ears, this means it wasn't from shooting a rifle, it was from the background noise of battle that he became deaf. This is the student flats that were paid for by Mr. Stevens generously at Jesus College. And as a consequence of his fame and fortune and generosity, he became an honorary fellow of Jesus College and had the CBE for his invention of hearing aids. He became an honorary fellow of the Royal Society of Medicine and an honorary doctorate at the University of Wales. And here he is with his wife. And some of his children are here in the audience. I'm afraid Peter, his eldest son, died. Only this son, I believe, is still alive at the moment, who is the deputy chairman of the Daily Express. But I'm very pleased that Peter's son, who is the direct heir to the crown of the Stevens family, is my colleague, Dr. Howard Stevens, in the front row. And he's a consultant dermatologist who went to Jesus College, and he was the identifier of the first gene to cause inherited deafness in humans. So your grandfather would have been very, very proud of you. And he also is a skin cancer surgeon and Mohs micrographic surgeon. So it's a great honor that you bothered to come, because you know all this better than I do. So now, skin cancer and sun addiction. And God said, "Let there be light." And there was light. And of course, he said it in Welsh. And he said it was good. And sunlight is good. It gives energy to the world, photosynthesis, life. We could not live without the sun. It helps our mood, our well-being. Physical activity is mostly conducted in daylight hours. Circadian rhythm, it helps us to know when to go to sleep and when to wake up. But we have slightly changed our relationship with sun in 100 years. And it did take us rather longer than 100 years to develop the evolutionary mechanisms with which we live at the moment. So here, this is the garden near where we live, and you can see humans seek the sun. Whereas here in Bermuda, birds seek the shade. Maybe they're telling us something. But there are many benefits from sun. Acne, psoriasis, eczema, itching, all of these benefit from sunlight. It's a very important tool for a dermatologist like me. It's a very potent drug. And like every drug, it has good and bad. There's a balance to be had. But we're very intrigued by something, and that is that sun seekers live longer than those who do not. So me, who's been running from tree to tree to seek the shade for so many years to try to preserve my complexion, I realize it's going to cost me years of Anno Domini. And that is despite the melanoma mortality. So if you rule out the melanoma mortality or you rule it in, it doesn't matter. You still live longer if you're a sun seeker. So I'm not going to persuade you to keep out of the sun. Bone health, internal cancer is less common in sun-exposed people, hypertension, cardiovascular disease, dementia, multiple sclerosis, respiratory infections, tuberculosis, myopia, macular degeneration, all of these are benefited by sun exposure. So how does it work? Well, through vitamin D for bone health and probably for colorectal cancer. So if your vitamin D is higher, you're less likely to get colorectal cancer. But then sunlight of all-cause mortality is not totally dependent upon vitamin D. And there have been many studies now where they just try to supplement vitamin D, and people do not live longer. So it is not simply vitamin D, it's something else. One of the important somethings else is something called nitric oxide, and that's an important vasodilator. And vasodilatation is very important in keeping your blood pressure down. And that brings down cardiovascular mortality, which is the biggest killer in the Western world. So if you have high blood pressure, you're likely to die of cardiovascular diseases, and sunlight helps to prevent that. Fat mice irradiated with sunshine, their weight goes down, their glucose intolerance goes down, in other words, their diabetes improves, and their fatty livers become less fatty, and their bad cholesterol goes down. There's quite a lot of research from various different people now. But sun is bad. As a dermatologist, I must tell you, sun is bad. The commonest human cancer is skin cancer. It's more common in Britain than all other cancers put together. 1 in 5 of you in the room at least, because you're probably a selected population. It's probably more like 1 in 3 will have skin cancer in your lifetime. The main cause is sunlight. 1 Briton dies every sunlit hour of the day from skin cancer. That's melanoma mainly. The types of different skin cancer, melanoma and non-melanoma skin cancer. So it's important to focus on this side for a second, and that is that there's, for you to make sense of the rest of the talk, there are 3 types of skin cancer. Melanoma, which is 10%, basal cell carcinoma, the commonest, which is 60%, and squamous cell carcinoma, 30%. So if you remember those 3 abbreviations, that'll be useful. The baddie is, and also the baddie causes photo damage. Now, if you think that there's aging of the skin, you look at people and you think, oh, they're old, and they look old. They actually look sun damaged. 90% of what the general public take for aging is actually sun damage. So if you don't go out in the, even though you may shorten your life slightly, you will not look your age. Sunburn. This is the first type of sun damage that really hits people when they're children. And 2,000 or more Scottish adolescents, half of them burnt last summer, and 20% burnt more than once. Well, they are slightly more red-haired in Scotland, and they probably hadn't learnt at this young age that they were, by the time they're adolescents, they ought to have learnt that they will sunburn. But of course, they are Scottish. Actually, no, I mustn't be nasty about the Scottish, because I'm Welsh and I'm on the side of Howard, you know, and I'm also fair. Now, at the beach or at work, you can be exposed to sunshine, and here you can also, there are many hazards of sunbathing. Here's a man on the beach here, and look at this. Oh gosh, that was a near miss. Right. And so ocean sailing, if you're on the water, 5% reflectance off the water, in addition to the 100 that's coming off the sun. If you're in the desert, there's 100 this way and 40 coming up at Beaugest's face. And if you're by the poolside, and they're 50% coming off the concrete, but not off the surface of the water, which Hockney shows to be rippled. And snow, new snow, 90% reflects. So this is a crazy girl here, because she is getting sun 190 instead of 100 of sun. So, of course, on the exposed areas, we become sunburnt if we overdo it. But even more interesting are the edges of clothing areas. You see here the difference between sun and no sun. And here on the third day of the holiday, this person has worn a slightly smaller bikini top or not put the cream right up to the edge, and there's been a little bit of burn just at the edge of clothing sunburn. So it can be bad. And you can sunburn your eyes, and this is photokeratitis, or sunburn of the eyes, also known as snow blindness. And remember that there were 3 types of skin cancer. There are 3 types of radiation from the sun, but you only have to remember 2, UVA and UVB. But UVB is the one that really causes most damage. Tanning. Well, there's a perception of beauty, and this is in part attributable to Coco Chanel, who said that being tanned is the index of chic. And in the 1929 girl must be tanned, said Vogue. So there's a lot of media messages, and then that led to bathing suits changing. And then extraordinary invention of tanning salons. Skin phototypes. Of course, it's not just the exterior, it's not just the environment, the sun. It depends on you as well. So if you have a phototype like this, you're going to burn much more readily than a phototype like this. So basically, that's Mediterranean, type 4. And type 1 is Scottish, Welsh, Irish. And here we can see them again. And so, but I think more helpful than knowing about the phototypes 1 to 6 is thinking in even more simple terms, and that is tannability, burnability, and molability. And if you inherit tannability, it means you can tan. And hands up, everybody here who can go a bit brown. Can you all put your hands in the air? A bit higher, a little bit higher. So that's the majority of you. Okay, arms down. Now, can you put your hands up if you can burn? That means go red, prickly, itchy, a tiny bit peely. That's half of you, a little bit less than half, slightly fewer than. And hands up if you've got more than 20 moles on your arm, or more than 50 on your arm, or more than 50 moles on your body, if you think. And they only have to be tiny ones. Put your hands up in the air. I should have put my hands up to the first 2 as well. Hands up a little bit higher. Don't be ashamed. Don't be ashamed. I'm sure it's co-inherited with very many good things. Okay, that's good. So it's about maybe 10, 15% of you. So if you have the triple inheritance, you are at particular risk, because the tanning lulls you, my children included, into a false sense of security, and you go and tan. But at the same time, you're burning. So of my children, 1 burns. And when she's in the sun, she's going brown, but she's also going red. I can see when I see in the evening, I touch her and she's pink. The other one doesn't. And the third one is still under the influence of the father. The one that burns also has moles. Every time she goes into the sun, she is going brown, and the moles are being burnt slightly. And then the next time they rise a little bit more, and then she plays a Russian roulette each time she goes in the sun. When she tans, she burns, she rises the moles. It's a danger. Now, what are the risks? So, this is a survey from my national health practice at that time, where 1,000 new patients, there were 243 who were referred, new patients with malignant or premalignant disease, and 161 with benign tumours, basically with the question, is it or isn't it cancer? So the majority of national health dermatology is skewed towards that sort of thing, and not, as you might have thought, eczema and infections and psoriasis and rarer diseases. Now, of the 243, and it's interesting, we published this and compared it with a diagnostic register in Ghana. And in Ghana, the commonest was infections by far, and there were 0 cancers of the skin. There was 1 lymphoma and no cancers. And it's, of course, attributable to the phototype. So here, we're looking at, you've been getting too much sun, Mr. Icarus, and the biopsy results. So what type of skin cancers were they? Of those 243 that were malignant or pre-malignant, 95 were basal cells and 63 were solar keratoses which is a pre-malignant condition, squamous cell carcinoma 50, and there were some invasive and some not, and 18 melanomas. And then this condition, atypical nevus syndrome, which some of those people who put your hands up saying you have lots of moles, probably the majority are in that group. So melanoma. Who has read Treasure Island? Hands up, please. Or seen the film, that'll do. Good, okay. So this is Blind Pew, and he is delivering the black spot. And Jack says, "But what is the black spot, Captain?" And the captain replies, "That's a summons, mate." And that is a summons. If you get the black spot, you must go without delay. 2 weeks is fine. It's the 5th commonest cancer, UK cancer, in Britain. That's melanoma. That's not counting all the other skin cancers, which are 9 times more common than this one, which aren't even in the statistics for some extraordinary reason. But melanoma is the 5th commonest UK cancer. It is common. 50% increase over the last 10 years, doubled since the early 1990s, tripled since the 1970s. 1 in 50 of the British population will get melanoma. So in this room, there are 250 people. That's 5 melanomas. Of course, it'll be skewed towards melanoma here because we have people interested in the condition. So 1935, there were 1 in 1,500 and so on. Look, you can see how it's getting more and more common. Here's the graph going up, not showing any signs of improvement. There was a massive exercise in pigmented lesion clinics and calling patients in. And so we shifted this bit of the graph leftwards for a couple of years with a lot of effort, but it's gone back to the normal line now. New melanomas every year, and deaths, 2,500. So it's a considerable cause of mortality. 86% is calculated as related to light. The 2nd commonest cancer in children and young adults in the United States, and they have a very big black population too, who are more or less immune. Non-Hispanic Caucasians in the United States, 26 get melanoma out of 100,000. Hispanics, that's the type 4 Mediterranean, 5. And the African Americans, of course, remember they're partly white, had 1 melanoma. And the risk factors are red or auburn, not sunburn, auburn hair, green or khaki eyes, freckles, and many and various moles. That's the atypical nevus syndrome, and a history of sunburn. These are the things to really watch out for. And a personal family history of melanoma. So if you have in your history 1 person with melanoma as a grandparent, or better still 2, your risk of melanoma is extremely high if you're a sunburner who also goes and tans and has moles. Risk factors in sunburn, especially in childhood, sunbed use, a simple blistering childhood sunburn, it doubles your risk. So you only have to have sunburn once to double your risk. And daily sunscreen halves your risk. The demographics, all ages are vulnerable to it. It is a common condition amongst the rare deaths from cancer in young people, but in older people, melanoma is much more common than it is in younger people. And that's the part of the demographic which is most rising in the last 20 years. It's older men. So I thought I'd escape the problem, but now I'm actually getting into the bracket where I have to watch out. And then this is the sort of people with funny moles, which I'll say some more about, many and various moles. If you have more than 100 moles, then you have 64 times more risk of melanoma. Celtic skin, sunburn in youth, past history of melanoma, all these. If you've had a melanoma, you've got a good chance of getting another one, 1 in 10 chance of getting another one. Early diagnosis is cure, and late diagnosis is death. Now, that's true with many cancers, but with melanoma, it is so much of a contrast. If you get it early, it is cured. If you get it late, we are, well, until recent years, we've been really more or less powerless. At 1970s, 5 in 10 died. So we're doing better now, only 1 in 10 die. That's mainly because we take them out earlier, because people present earlier, because of knowledge. Early diagnosis and also prevention, but prevention hasn't kicked in yet. We're still on early diagnosis. Trunk and legs are favored. And look for the black irregular pattern here. See, it's a shape. Just a second. And notice that he has freckled skin and his hair is slightly reddish. That's typical. And he has tannability, burnability, and moleability. There's a mole down here, you see. Here are a range of quite advanced melanomas. If a patient comes in like this, I mean, of course, we want to help them, but we're just a little bit disappointed that I should get them as late as these. You know, this would be, we hope to get them sooner. So look out for asymmetry. If the border is irregular, if the color is variable within the lesion, if the diameter is growing, or if it's getting bigger, or if it's any change you see. And I use this special magnifying glass, which helps me to see a little bit more detail when I look inside them. So I can see little patterns of dots, which give me extra information. And that's a picture of a melanoma. So you don't have to be an expert to see it's got an irregular border. It's quite big. It's got varying different colors of pigment throughout it. It looks bad. It looks as if that would be definitely a melanoma. So here is what we do for them when we cut them out, and these heal. So I take this out and I leave nature, God, the first slide in Welsh, just heals the hole without any sutures at all, and it comes like that. So here's another one. So taking this one out, leave a big hole like that, because you have to take quite a margin sometimes with these, and that was 3 inches across by 1.5 inches, and then the wound just heals like this on its own. It doesn't take 14 months to heal. It takes about 8 to 10 weeks to heal, and if you try and suture them, you have to extend this incision to here to make it longer, and you have to burrow under here and under here in order to loosen the sides to bring it together, and then you'd have stitch marks here and a longer scar. And very often they do spread a little bit anyway. So this is a very good way of doing it. And it doesn't hurt at all. The healing is absolutely painless and no restriction on activity. So, but sometimes we have to stitch them. So here is someone, that's the initial lesion taken out by superficial excision. And then I've got the microscopic examination, which we measure, called Breslow thickness, which gives us an indication of prognosis. It depends how far these cells have come down here as to how well the patient is likely to do. So now I have that information. I now need to take a little bit extra, 0.5 centimeter in this case, and then a hole like this, what do I do? So I thought, well, I'll extend it along here and along here, because those will be invisible along the lip. And then I've got to try to get this all together. So then I thought, well, I'll go a bit more down here, pull this across here, try and pull it together, try not to make them look like a swastika. And then, but it wouldn't matter actually, because it would be invisible at the end. And then stitch it all together. So I've stolen a bit of the lower lip and put it in the upper lip, and then take the stitches out after a little while. And then at 18 months, you can barely see it. But this takes much more time, and the patient has to look after the wound post-operatively. So, but at a free edge, you need to do that. Now, some interesting cases here. This is a synchronous conjugal melanoma, husband and wife. They were both keen sailors. They had sailed around the world, and she came, and after I'd seen her, as very often, she said, "Oh, I think you better see my husband," and he came. So they were within a couple of weeks of each other, and that was on her left knee. She'd come with something else, and he'd come with something else, and total skin examination showed these. Anyway, they have relatively thin, and so the prognosis is excellent. They can regard themselves as that's the end of it. Ocular melanoma 5 years previously. So it can begin in an eye. It doesn't have to begin on the skin, and because there are pigment cells in the back of the eye, and then a glass eye has been put in here. Not by me. And in order not to get melanoma, you need to avoid sunburn. Avoid deliberate tanning and sun tanning. I think sun beds definitely don't do that. Deliberate tanning, probably you should avoid deliberate tanning, especially if you are freckled or moly. because deliberate tanning almost always means burning in these susceptible people. Early diagnosis means cure. So now the precursor lesions are the atypical nevus syndrome. That's that you put your hands up, about 15% of the audience. You said and young adults, it's common. It's a melanoma. I see these at the beach all the time. And so that's not unusual. You know, that's somebody's back with half a dozen moles, and there's one that's been taken out somewhere else, not by me there. And then here's another one, and that we'll come back to that scar later. Many and various moles. You see, they're all different. So now these are very, very extreme cases of atypical nevus syndrome. So there won't be many people in the room here. There'll probably be 3 or 4 people, or maybe 2 or 3 like this in the room. So it's not that rare. If you go to the beach, you do see them. And they fade with sun avoidance. So as older people, I examine everybody from top to toe who comes to see me, and children don't have this, and people of 75 don't have that anymore. It goes away. And they sometimes also have iris nevi. So notice in the lower pole of the eye, so this part is shaded by the upper lid, and this gets all the sun down here. So it's interesting when looking at moles, remembering Sherlock Holmes and the case of the dog that didn't bark in the night. You'll remember that this is because, what was the absence of the evidence is what he was interested in here. So look at the absence of the evidence here on the sun-protected area, relative absence of nevi, and preponderance of them, not just on the sun, but on the edges of the areas that people burn. Edge of clothing sites, the famous builder's line. Sunburn at the t-shirt line, that's a precursor. That's going to be trouble there for that person later, and this might be that person later. You see, look, 1, 2, 3, 4 at the line. So you wear a t-shirt that comes to here, and then on the 3rd day of your holiday, you think, oh, well, a shorter one, and you get burnt in a stripe. It happens at the edge of bikinis as well. T-shirt line again, a nice line of 3 moles at the t-shirt line. The G-string line, the shorts line, and we see these in all parts. So in patients like that, it's very, very helpful to have mole mapping. We take pictures of everybody from top to toe, and that gives us the opportunity to follow these moles using the dermoscope and looking at them and seeing that that's a benign one, but I want to watch that one. And here, this is amazing that we can see them over time, you see, slightly changing, you see, beginning to get dots here. So that's the mole changing. But now look more closely at the mole and look at the dots. So can you name these Australian cities? But that's a true mole, actually. So here's another one, clustering around the distal thighs, where the clothes are not always covering. This is how we would remove one of these. This is in real time. I might speed it up a little bit so we don't. I think it's interesting to see how easy it is. So I'm splitting the skin here. It's a plastic surgical technique that McIndoe and Gillies developed, and they tried to keep it secret from the general surgeons, I understand, and because they used it for split skin grafts, and were very sad when they heard that the others were using it. Anyway, I fell upon this technique, and I saw it in America, and it's a very, very good way of taking out these moles, and without breaking the back of the skin. So for the doctors in the audience, I'm not breaking through the dermis at the back, and so recovery can occur over this little area, and the new skin can come in from the sides and up from the hair follicles. I've got all I want microscopically, and then we can put a little dressing on there. Actually, I've just prepared that for the microscopic examination, and then I'm just checking to see it's all gone with that little thing, and then we put that in a little plaster over the top, and it's all finished. So and then we're on to the next one. Come on, nurse. So thank you. So this to this is less than, that was real time, that was 1 minute and 30 seconds, I think. And that's what I shouldn't boast, because amputationists in the good old days, used to get the limb off in less than 1 minute. So, this is the specimen that we get, something like this, with lentiginous genital, funny mole with a little bit of funniness in it. Here, this is, and you can see the cells not looking quite the same as in other places. So that's not a cancer, but it's going towards it. So that's if we had taken out with an ellipse, and you see the stitch marks, that's the traditional cut and stitch. And that's if you take it out by this technique. And so on this patient here, ellipse, excision, and sutures, and the same patient, superficial excisions and no sutures. So there are barely any marks to be seen. So it's very quick, it's very easy, it doesn't scar, and it means that we can make our biopsy rate very accessible. So we consider annual total skin examination by a dermatologist if you have more than 50 moles, or more than 20 moles on your arms, or if you have a personal history of skin cancer. So total skin examination is a very important part of the dermatologist's approach. It's routine in my practice for new patients and for follow-up patients every year. And many things are discovered, and in a 5-year period, of the 102 melanomas that were diagnosed by me in my practice in 99 patients, here they were, many on the face, but many on covered parts also, and arms and body. And the ones that were the presenting complaint melanoma, in other words, the doctor had sent them, or the patient had come with it, and the other ones, the ones that were opportunistically diagnosed. So in the 5 years, in a routine dermatology, of 102 consecutive melanomas, 32 were discovered by routine total skin examination. So it means that total skin examination found their melanomas early. So 1 in 3 melanomas, and so that was, we published that in the British Journal of Dermatology. And then if that were extrapolated throughout the country, 32 melanomas by 1 consultant in 5 years, that's 6.4 per consultant per year. In those days, there were only 300 consultants, now there are 850 dermatologists, so maybe the numbers wouldn't be quite the same. But the implication would be similar. So if you think that there are 2,500 deaths a year from melanoma, and 1,500, and there are 15,000 melanoma new diagnoses a year, this would make a substantial difference. And that's not just my, not just that study. I've done it in a different way. I looked at 200 consecutive patients at a different time, a couple of years ago, and excluding what they came with and what they knew they had and what their doctor knew they had, but including their tail of visits to see me. 41 of the 200 had 117 skin cancers. They didn't know anything about this, including 6 melanomas, these discovered by routine total skin examination. And this is not only my experience. Here in 1,800 patients in a skin cancer dermatology clinic, of 38 consecutive new patients, 14 were diagnosed on routine total skin examination. It's a Scottish group here who always do total skin examination. And they stated the importance of a full clinical examination, assessment of index lesions, that's the one they come with, referred to a skin cancer clinic without a total body skin examination would miss 1 in 3 melanomas, which is exactly my experience. And so since early diagnosis, better prognosis, simpler treatment, saving money for the health service. And remember also that there are some associated conditions with skin cancer, one of which is Dupuytren's contracture. And so that's a tightening of the fascia of the hand, and which I see a lot of patients with this because I treat them with a needle, not with surgery, and they can walk in and walk out like that. But these patients are at greater risk of basal cell carcinoma, which is the next thing here. The commonest human cancer, the most curable human malignancy. And that's the sort of age distribution. And head and trunk, and this is what they look like, well-defined, erythematous, that means red, shiny. Sometimes they're rather pale little things. Bumps, raised, rolled, pearly-edged telangiectasia. And there are various different techniques here for treating them. And so the one I favor usually is curettage and cautery, or electrofulguration, another name for the same thing. And so this is a patient who took serial photographs of her healing wound. And so over not quite a short time, those type of wounds heal. And then here's a patient who had a cancer here on just south of the eye. And so it's quite a big one. This type is difficult to find the edge, so you have to go a bit further. That's the most gruesome picture today, sorry. And then here's the healing wound. And then here, 4 years later, no stitches, no repair, nothing. It just happens on its own, just natural healing. And then a few more examples of treatment of the commonest human cancer. And so these are very simple. It doesn't, post-operative doesn't hurt. And here's a rather remarkable one here. So very little to see at the end of it. And so there's nothing to fear. Now, if you have it on the lower eyelid, you have to take it out and cut a little hole like that. But again, you can leave this to nature. And here, here, that's just, does it on its own, heals on its own. So if you've had one basal cell carcinoma, you have a good chance of getting another. If you follow patients up, within about 38 months, the average patient, half of the patients will get second cancers, and they're evident at by about 3 years. They're unrelated to the first, except that it's all the same story of sun. Solar keratoses, these are the precursor lesions for squamous cell carcinoma of the skin. And here's an agricultural worker, and you can see where he's been covered and where he hasn't, and where he's developed the solar keratoses. And there's the potential to evolve into squamous cell carcinoma, which is the third type of skin cancer, favors the elderly. And these look like this. And they like the lip very much. And here is another conjugal pair of cancers. Here, conjugal squamous cell carcinomas, his and hers. And they had conjugal companionship for many years at the seaside, sitting in the deck chair. And they're slightly facing towards each other with that leg, the outer leg facing towards the sun. And so they had them on the mirror image legs. So it was a perfect example of conjugal squamous cell carcinomas. Now, there are diseases associated with non-melanoma skin cancer. And all of these cancers are associated with basal cell and squamous cell carcinoma. So a finding of a skin cancer means you should also examine the patient generally, or at least consider it. And so these patients are at greater risk of all of these disorders. So you should consider an annual total skin examination by a dermatologist if you have solar keratoses, a personal history of skin cancer, history of sunburn, and if you're now over 60, so if you had sunburn earlier and now you're over 60, or Dupuytren's contracture, or immunosuppressant treatment. Many diseases need immunosuppressants, which suppresses the body's way of controlling cancer. But then there are many other aspects, non-malignant damage from the sun that is so evil. And the first one that you might see in your children are freckles. So freckles are not only sweet and pretty, they're also a sign of reversible at that stage, solar damage. Incubation period for sunburn, 2 hours, suntan 2 days, freckles 2 weeks, brown spots 20 years, wrinkles 30 years, and skin cancers 20 to 40 years. But the mole side of things is a different evolution. 2 years for the moles to come up, and 2 to 20 years for them to turn into melanomas. There are many non-malignant manifestations of sun damage. Leathery skin, this is a famous picture that you've probably all seen in magazines. A left-hand drive lorry driver from North America, and an Amerindian, and photo damage here. This was called, when I was a student, sailor skin. on the back of the neck. And seborrheic warts, these are from the sun very often, these brown blobs, very easy to remove. And brown marks like that, also very easy to remove. And you can show these up much more readily if you use ultraviolet light. And this is a very good way of incentivizing, especially younger people, to use sunscreen. You can show them what they're going to look like when these reach the surface. Some people get white spots. These will never be cancerous, but it's the company they keep. And the back of the hand, white spots here. And we can get rid of these things very simply. We just go the little brown spots and the white spots. It's just like that. Just squirt them with a little. And if I do that on 2 or 3 occasions, they'll all disappear. And you can get broken veins too from the sun. And these are also very simple to get rid of. So we just go like that. It's terribly quick. And do this over about no eye protection required or anything. And if I did that 3 times, those would disappear 90%. And I used that also in breast cancer patients who get broken veins after radiotherapy. Solar dermopenia, this is the one that no one knows about, which is very pernicious. The skin starts off this thick, and when you're exposed to sun, it becomes thinner. As the upper dermis, that's the epidermis, the dermis, the fat, the upper part of the dermis thins, you begin to see through it to the structures of the deeper dermis. And so here we can see the shaded upper neck above this line and the sun-exposed lower neck with a very sharp line of demarcation, the chin shading here. And here again, that line of demarcation. This is happening all over your sun-exposed skin. It's just here you can see it very easily. And this is the dermopenia with sebaceous gland hyperplasia, all those little dots. So the skin is being thinned, but the oil glands are getting bigger. Many patients are not really aware of this until you show them in a photograph. And then the skin becomes thin and makes little fine lines. Nobody wants these things. But these are all from sun exposure. But look, aged 15 with acne. Here's his neck. He looks like a normal chap. Look more closely, and we can see the changes beginning in this part of his neck, the unshaded part compared with the shaded part. And then here is the red neck that from Texas, solar erythema. This doesn't really determine you mean that you will vote for Trump. Not necessarily. A little word about sunbeds. And here is a patient with, you see the 3 white, the places, white areas. These 3 and those 2, here they are, they give a clue to me when I examine a patient. Have you been on a sunbed? And they say yes. Well, they may even try lying, but and you see sunbed here and here, and that's the G-string, but that's the bikini. This is the sunbed. Slight scoliosis, so only on one side here. And the sunbed, suntan, sacroscapular sparing sign. And this happens because when you lie on the sunbed, you lie on a perspex. The sun, the light, the artificial sun is shone up through, and this is where the points of pressure mean you squeeze the skin out so that it's white. You need oxygen to tan, and so where the pressure of the body on the plastic is, there's no blood, so there's no oxygen, so there's no tanning. Sun protection. This is the answer, of course. And this is a nice patient of mine who took her hat off for the photograph to show me the nice pajamas she wears when she goes to the sun. And these could well be patients taking my advice. But don't forget, you don't have to wear sunscreen. If you're 1 or 2 fists to the horizon, if the sun is below this line, you don't need sunscreen. That's about 1.5 hours on the way in and 1.5 hours on the way out. But the rest, and there are 14 fists if you go all the way around here. So 4 of them are okay, but the other 10 are not. Here is a very good sunscreen called Hair. And here's a sunscreen that I think she wasn't intending. And you can, if you want to have a very effective sunscreen, use zinc or titanium. It's a physical blocker. But even the organic chemicals which are the ones you usually will buy, they also block very well. But most people don't put their sunscreen on properly. So it's better to have to, this is too complicated. Remember, try and get a high number with stars. That means you've got A and B protection. You have to put it on very often if you want to rely on it. A shirt is much better. Sun addiction, is this an urban myth? Well, there's a desire to tan, a cosmetic desire. In students in Cork, they found it was associated with the female gender, enjoyment of tanning, of course, peer pressure to tan, many of them were smokers also, and most of them, not quite reaching statistical significance, felt it was worth even burning in order to tan. Everybody finds females, the ones who do this mainly, often associated with some other activities like dieting. Interesting, if your parent allows tanning or encourages it, or you have a friend who tans, you're more at risk. Tanning by lamps is associated with watching TV beauty shows, reality TV beauty shows. I knew you'd want to know that. So is desire to tan a substance-related disorder? And there's a definition of this. Well, an addiction is a compulsive engagement in rewarding stimuli, despite adverse consequences. So you could say short-term reward for with ignoring long-term cost. And dependence is an adaptive state with a withdrawal syndrome upon cessation. So there are ways of looking at alcohol, and they've been applied to suntanners and various questionnaires given to suntanners. And the results of these, if they answer these questionnaires in a positive way, we can determine whether they satisfy the criteria for DSM-4 and for substance abuse. And 20% of beachgoers do. And 24% of non-Hispanic whites who were using tanning parlors. And so it is widely believed amongst dermatologists that it is a type of substance-related disease. Tanning dependence, this is undergraduates, so intelligent, above average intelligence people. But these are associated with some other conditions. So we see these people are susceptible to other type of substances also. It's the same message in all of these papers. Exercise addiction also, seasonal affective disorder. Treatment, there is treatment, cognitive behavioural therapy, antidepressants, addiction therapy. So is it just a desire, the desire to tan, though perhaps not just an addiction, which is something we should cure, or is it an evolutionary survival advantage? So there's some interesting work where they've taken skin cells, the top layer, keratinocytes, and they've looked at the opioids. You see, this is opioid-like morphine-like compounds. And from this is derived melanocyte-stimulating hormone, which makes you tan. But also from the same base, from this POMC, are derived skin beta endorphins. And these are the endorphins. This is the endogenous morphine. And so much is produced with ultraviolet irradiation that it gets into the bloodstream. And it raises the pain threshold for rodents in this experiment. And it was reversed by opioid blockade. So there's actually a systemic effect from sunbathing, which is rather like taking morphine. And this has been shown also that when they withdraw the sunshine, they get withdrawal signs, which means they're dependent. And they also choose, if they can, to be irradiated rather than not. They avoid the non-irradiation. And if you take knockout mice, so you can do some experiments, you can take some special mice that are unable to do some of these things, then we find these mice do not develop dependence and tolerance. So there's a chemical pathway which is built into the DNA. And it's true in humans too, beta endorphins from sunshine. And this gives a pleasurable action. And when you take it away, it's less pleasurable. So why do we have this primordial ultraviolet addiction? Well, perhaps it's for vitamin D synthesis, but maybe also for other ultraviolet benefits. It's probably an evolutionary survival advantage. And so we know that MSH, that's the other POMC derivative, doesn't just cause pigmentation, it also affects feeding behavior, makes people thinner. It affects energy, and they burn their calories more quickly, and sexual activity. And the inventor of this injected himself with it and had an 8-hour-long erection. So maybe some of these effects are desirable. So sunlight causes vitamin D to rise, nitric oxide to rise, which is the one that makes your blood pressure go down. It may be the one which is something to do with sexual activity. It's the one that turns off seasonal affective disorder, raises endorphins, and it's an immunomodulator also, so very useful for treating infections. So in conclusion, 1 in 5 in Britain will get skin cancer. Skin cancer is the commonest UK cancer, and 90% of skin cancers are preventable. Remember that tannability linked with burnability is a high risk factor, and much higher if you add moles into the mix. Routine total skin examination in selected people will help early diagnosis and save lives. Tanning dependence does exist. Tanning dependence does cause skin cancer, and ultraviolet addiction may not be just a bad thing, but it may have evolutionary and psychological benefits, which we all are benefiting from. So in conclusion, sun seekers live longer, and sun provides important physiological benefits. So we mustn't throw the baby out with the bathwater. But if I haven't rammed home the message about melanoma enough, I urge you to watch this on YouTube. So, Dear 16-Year-Old Me, you can find it on YouTube. And any of your family or your friends who are over sunbathing, especially if they have moles, should watch that. Thank you.